what's some of your favorite strategies to try and, I guess, educate them that load is their friend, and it's about finding that like rational plan and gradually building up, like you said.
There might be people who might have a perception of their injury and might be driven by kinesiophobia, maybe some psychosocial factors as well. So a lot more sort of conversation, more reassurance will be required. And again, maybe you might need to take things slowly. But for the typical athlete, I'd say, who competes at a high level, where you're fairly certain it's biomechanical overload and poor capacity, inability to adapt, it is a question of a case of hitting the reset button, dialing things back, find the right entry point to start rehab and start loading the tendon and then progressing from there. If the tendon is really painful, it might be doing some long isometric holds as just some way of starting the process. If and where they can, I try to get into some dynamic loading when they can tolerate it, working into dorsiflexion, doing slow, steady calf raises, like a 3 second concentric, 3 second eccentric load per rep.
What are the most common mistakes that you see? Is it the psychosocial the area that might not be addressed, or is it like you talked about, the pain compared to function? Is that an area that, whether it be practitioners or perhaps athletes, are missing there? Or where do you feel the gap is at the moment in the industry?
So two things. Look at the simple things really well. How are they set up to do a calf raise and tidying that up? I find myself doing that a lot of the time. And the same when they do in plyometrics. A lot of people tend to be untidy on the ground. They hit the ground a little bit behind the toes, and they have a lot of like softness on the foot as they're absorbing, and a lot of energy leakages, and not a good way to load the tendon because you're landing with slack in the system, and tendon has to quickly stretch before the muscles figure out what's going on. So trying to promote more active dorsiflexion during flight phase and a little bit more of a flatter foot contact, or at least active plantarflexion at contact, and getting a better energy return off it. So oftentimes tidying up that.
And over, I guess, the last decade, has there been an increase in these type of injuries? Calf, gastroc-soleus, Achilles, tendinopathy, you mentioned plantaris. Have you seen higher incidence, or is it maybe more severe but less of them?
Probably seeing a lot more recurrent calf injuries. So in those cases, again, similar to the Achilles, looking at the calf, looking at their individual morphology, are they dominant in one muscle over another? And even the soleus, if I have the benefit of seeing their MRI scan and their images, looking at their muscle compartments and looking at their aponeurosis shapes. Have they got a larger intramuscular aponeurosis in the medial side compared to the lateral side? Are they affected or unaffected side? Is their central tendon more medially or laterally deviated, which will mean that they're going to have a bigger medial or lateral compartment? And sometimes if they can be overloading and injuring their more dominant compartment, and it might maybe focus a bit more on developing their non-dominant side. So if they got a injury to the medial intramuscular aponeurosis, they got a dominant medial compartment. When I look at them, just look at them kind of standing back, and I see that they got an undeveloped lateral gastroc, they're weak in eversion, they're totally underdeveloped on the lateral side. I would be trying to target that, maybe build a bit more hypertrophy in the lateral compartment of the soleus, develop the lateral gastroc, develop the perineals, and just make sure they got better force distribution around the whole lower limb complex.
And since bringing ultrasound into your practice, what has that changed in terms of whether it be your methods or, I guess, exercise prescription or dosage? What have been the biggest changes?
Most of us now are moving towards Carlos Pedre's classification system using ultrasound. Again, in the clinic, we always use MRI for diagnostics. That's our main go-to. So I would see ultrasound as being complementary to that. So I would, particularly for those medium to high grade medial gastroc strains, where you see a loss of synchronous motion between the gastroc and soleus, I'd be looking to get that restored quick enough. So every time I see the patient or athlete, I'd be checking that and seeing if we got that restored synchronicity of the two muscle heads. Any signs of hematoma between the muscle heads, and if there is it receding over the course of rehab, or making sure there's no kind of hard fibrotic scar tissue forming that is going to impact, I suppose, shear between those two muscle heads. And then looking for signs of remodeling those fascicles that are potentially involved.
Any other monitoring tools that are your non-negotiables if you were to set up a clinic? Or
well, actually, just going back to the tendon, what I have moved towards now is trying to measure tendon strain, sticking a strap on that keeps the probe fixed over the skin and getting to calf raises of different intensities. And we know that the tendon adapts positively when the strain is between 4.5% and 6.5%. For example, if someone's got a 20 centimeter tendon and you're getting 1 centimeter of elongation, that's about 5% strain. If you use the medial gastroc MTJ as a reference point for displacement, and then obviously you got to account for a little bit of rotation of the calcaneus, so that might be an extra 0.5 centimeter or so. So we know that if they get 1 centimeter of elongation of the medial gastroc kind of pulling and elongating the tendon, that they're getting sufficient adaptive strain. So it's how many kilos on a machine do you need to achieve that? So that's something I've been moving towards as well in my practice, and being able to individually prescribe their tendon loading.